most of you guys have seen me around here, but Marisol, I'm the new director for behavioral health emergency response and some other consultation liaison upstairs, and I hang out here with you guys quite a bit, not so much lately, but I am available all the time. You guys know my pager number. And then Willis has just joined the team. She is a nurse practitioner with psychiatry, and she is now also doing consult liaison and also consults with our birds and does many, many other things, including medication recommendations for our patients that are being very violent anywhere on the floors and in the emergency department. So it's a great new resource. She's also starting aftercare, so for our birds that are coming in here that we can't get connected and that don't meet criteria for inpatient hospitalization, she'll see them for the first 30 days to make sure that they get connected with services. So if we're sending them home with a safety plan, she's part of our safety plan, and she'll continue to work with the county in getting them connected or with their insurance and so forth. And we'll see them for a few sessions and continue to work on whatever was needing them to come to the ED in hopes of having them not come to the emergency room so frequently and also getting them long-term care. So it's great to have someone to send them that we didn't before, so we're very excited.
Wonderful new role.
Is there any way to get the intercom closer to Marisol?
Yes, I can try to speak louder too.
Thank
And
you.
Shanti Gooden will be here in a little bit. I don't know if you guys know her. Shanti Gooden is our psychiatrist that works also consultation liaison in BERT. She oversees the consults upstairs, but when there is also a patient that's agitated, she is the person that we call. She's one of our 3 on-call psychiatrists, so she's on call every 3 weeks, 24 hours a day, and then we also have Petra and Dawn who are on call. So we do have an on-call psychiatrist for the hospital, including the emergency department, 24 hours a day, that we can call and consult for medication questions or for other high acuity psych issues that are coming up, and that's always available to us, which is great that we have that resource, and Shanti's one of the people that really understands the birds, so we're glad to have her, and she'll be joining us in a little bit. She's just was one of our patients that was a bird before, so I'm glad she's taking care of that. So for the objectives for today, it is to better understand that etiology of difficult behavior, really knowing why they're presenting with these behaviors, what's going on, emotionally, psychologically, and in their environment that's causing them to act in this way, or that is leading for them to be in this crisis situation at this time. To learn some strategies to manage difficult behavior during an episode, and learn some strategies to plan ahead and avoid difficult behaviors. So the etiology of difficult behaviors, really why does it get to this point? And really challenging episodes occur when the demands exceed the capacity to respond well. So when the demands on the patient or on the parent are above what they're able to handle or manage, because they don't have the coping skills, they weren't able to develop the coping skills, or they're in an emergency crisis situation that their coping skills are not available to them, that's when we have a crisis. And that's when we usually have a patient that's escalated in the ED. And that's so common for not only for the births and the behavioral situations, but for the medical traumas and for anything that's going on that could be life-threatening. So that's when we see the patients and the parents get to this point, because we are not built and we do not learn how to cope with accidents or behavioral or psychological crisis. That's not something that we do every day, and that we're not really able to handle without some support of a system, and that's where we try to come in and support the families medically and psychologically. So the responding to a challenge will require flexibility, adaptability, frustration tolerance, and problem solving. So those are the key things that we need to keep in mind when we're dealing with patients and families that are presenting with behavioral outbursts. Let's see. So to keep in mind, children are very motivated to do well. So they do want to do well. That is something that comes naturally to them. So when they're not doing well, it's something else is going on, and we just need to keep that in mind. Challenging episodes reflect developmental delays in skills of flexibility, frustration tolerance, and problem solving. So we need to keep in mind that there is something that is not allowing them to use these skills.
Yeah. So we really want to make sure that
when we are responding to an escalated child or an escalated parent, we want to try not to take their behaviors personally. And so we need to then respond with greater compassion and model sort of the calm in the storm. We want to decrease the feelings that their behavior is intentional, and it's really easy, especially when we're fatigued and maybe we're over demanded. We want to kind of move away from the idea that this is malicious or this is excusing it as attention seeking or manipulative, button pushing, things like that, because the way that we think about the situation will shape then how we feel about it, which then in turn shapes how we act on it. So just being mindful of our own thought process around the behaviors that we're being faced with. And then just kind of summing that up, decreasing our judgments, that parents are permissive, passive, or it's the parent, it's because of the parents that the child is acting this way, because again, the way we think affects how we feel, which then affects how we're going to address the parent. And the parents will pick up on that sort of judgment and then meet you with further resistance.
So management during an episode. So these are the guidelines that we have. So listen, and this is before they become escalated and also while they're escalated. So listen with full attention. Really try to tune into what they're saying. Make sure that they feel like they're being listened to, and we're having to do things. We're having to take things out of the room, put things in the room, we take out our write something down. But if we at least reflect what they said in some kind of way, they'll feel listened to, and then they'll feel like we're understanding where they're coming from. Avoid advice and denying or minimizing the child's feelings. So that's a huge, huge one, I think, that I learned pretty early on, and it backfires when you try to give them advice and you minimize the feelings. So if they are coming in and saying something, it's really important for us to validate, which is the other one. So when you're giving advice, it does really feel like it's minimizing of their experience. They'll feel like you're saying that you know the solution when they've been looking for a solution for potentially many, many years, and you giving them advice in a couple of minutes of knowing them will minimize their experience of all the work that they've been putting in and how they feel about themselves and their ability to cope with difficult situations.
I just wanted to add on there too, oftentimes minimizing the child's feelings or even parents' feelings, we do it unintentionally. I find myself in my own practice doing it like, oh my God, just minimize that feeling of being like, no, it's okay, it's all right, when really it's important to validate the feeling and say, you know what, this is a pretty scary situation and this isn't going to feel very good. So just being mindful that it's not that we're doing it intentionally, it's coming from a place where we want to make you feel better, but that can be perceived as minimizing.
Just wanting to say things are going to be okay, that comes out of me all the time, but we really don't know if they're going to be okay, and we need to sit with them in that not knowing, and being able to sit with them in that crisis and in that uncertainty, it just goes such a long way, and not being able to tolerate it will, again, also help them not tolerate it, and both of you guys will end up in a stressful emotional situation yourselves. So validating and giving fulfilling the name. A lot of the patients, especially the children, don't know what they're feeling at the time. So when you are validating, like Monifa was saying, this is scary. This is a scary experience. Or yes, this does hurt right now. And yes, I know you want to be at home right now. Those things are helping the child name their experience and understand why they're feeling so either scared or anxious, because you will be able to identify those things for them. And you know the situation, you kind of see it, and you can kind of see their emotion. Many of our patients that come in with behavioral problems don't understand their feelings, so being able to explain or label the feelings for them is actually a huge intervention that you guys have the capacity of doing. Do you want to continue?
So I think she kind of touched on describing what you see. Giving the child his or her wish or fantasy is, and you kind of touched on that too, just sort of being like, home would be better, and yes, we do want to go home.
And I wish you were really healthy too, or I wish you were with your parents too.
Exactly. And space, I think this is important. When we say give space, when we say give space, people sometimes kind of focus in on physical space, but actually silences space as well, and being mindful of being quiet in the moment of chaos, or not responding to assaults, or verbal assaults I should say. That's giving space as well. So those are just sort of quick go-to guidelines when sort of managing an episode.
Okay, sure.
Welcome.
I was just doing my own de-escalation, and it ended up with mom storming out and slamming the door and speeding off, and
So you're well
the
prepared.
child threatening to kill herself, and the mom saying, well, maybe that's a good idea, and I'm like, this is all not right. Anyway, so sorry I'm late.
Perfect timing.
Yeah, you'll give us a great example.
I'm exhausted. So we want to listen with full attention, and that means with empathy, gathering the information to understand the child's concern or perspective about a given problem, and also the parents, clarifying and really trying to understand. So reflective listening, instead of just mimicking what the child says, kind of paraphrasing it. So I hear you saying you're frustrated with the wait. Open-ended questions like how, when, where, and what. When we use the word why, it sounds judgmental. Why are you upset? Why are you mad? It makes it sound like a judgment as opposed to what's making you mad. How is it going? When did this start? Where were you? What happened? And then breaking down into parts. So when you first walked in, what happened, and then what? I'm imagining that most of this, the escalation in the ER is around like procedures that need to happen, interventions that need to happen, and wait times. Waiting for x-rays, waiting for transfer, waiting for the floor. So, so you've been here since yesterday. You know, you're not really feeling well, and you're still waiting, and you're waiting, and what else is getting you upset? Okay. And then when there is expressive language delays, having visual cues to help a family or a child express their needs, and also having visual cues for solutions. So here's an example of something's the matter, or you're hungry. So what are some solutions, like, and whatever the pictures might be. I would love to have some of these made kind of for our most frequent problems that we see, and then using solutions that we actually have. We probably don't, well, we might, I don't know, we have cheese, but you know, whatever solutions might be an option. Right, so
Goldfish.
it might be a helpful thing. And just remembering that even when somebody's regressed because they're stressed or in an unfamiliar situation, their expressive language might also become of someone of a younger age. And then, so managing behaviors, trying to give medications the same way as at home, as close to possible. If child life is available, using them to help. And then things to reduce anxiety around medication is making it a game, communicating about it, doing like letting them give pretend medication to their parent or their stuffed animal, kind of practicing it, modeling it. Okay.
I know we're talking
Yeah,
for the child, but that's just
Yeah, so showing it first visually.
Right.
low exposure.
Yeah.
Not that we have time to do for that, but
Yeah.
as much as
No, I need to give advice to the parent.
Yeah,
on
yeah,
how to
yeah,
get
that's
the child
right.
So
to be
educating
compliant.
the parent is huge too, because the parent can then communicate in the way that's effective with their child, we hope,
Right,
in most cases.
yeah.
And so if the parent is really clear on what's happening, then
Mhm.
they can communicate that better with their child.
And
So,
Sorry, and you mentioned doing it in a way that they're familiar with, so I imagine that would involve the parents a fair amount too.
Yep.
They've got a system that works at home,
Right.
taking them that, we should allow that.
right,
Right, it might be that the airplane, fly it in your mouth,
Yeah.
maybe that's what
maybe a
works.
special cup, a special spoon. We can meet them.
Right, dissolving in a certain way. And I've definitely seen that before. I saw a mom in here giving her child, I'd never seen this before, she just took 2 spoons, crushed the clonidine, put in a little bit of apple juice, dissolved it just perfect, gave it right to the child, and it was like, and that's,
Okay.
it's not a way I would have known how to do, and she did it right away. And another one I heard about that we don't have in the hospital is using whipped cream. So you put the pill on the tongue and you spray the whipped cream on top of the pill, and it will, it's fun for the kid to do that, and it just, they swallow it because it's more natural, depending on the size of the pill. But we don't have, you don't have that access.
Especially not now. No whipped cream.
No,
No.
no.
Maybe ice cream.
Maybe,
Ice cream.
ice cream, something like that.
We have ice cream.
So ways to reduce anxiety, providing a new sensory experience, music, TV, the iPad, a toy. I know Child Life is working on getting this crazy machine that like projects light onto the walls. You can have like fish swimming around the room,
Cool.
and has bubbles in it and fiber optic cables that light up. So it's just a nice distraction.
And the other thing we have here is the heated blankets that we need to change, especially with our kids with some delays or some, like autism, but like having something warm or weighted on them will help them calm down. So just asking the parent what they use at home, but the warm blankets have usually at least get some of their senses going. So when it comes to distraction, getting the senses going, like, touch and taste and sight, and we're seeing something, they can see something. This hospital doesn't smell great all the time, so that's one of the things that we can't do, but we can definitely have something warm on them that is very comforting.
Up on the on floors, there was a mom who would come in for extended stays, and she would bring her aromatherapy kit, the things that do, it's like a humidifier, so it doesn't use heat, it just uses electricity, and then they would have the room smelling for their comfort. So, reducing anxiety, I know we always have like these huge teams, so maybe Bert will come in, maybe the resident comes in, maybe the attending comes in, nursing comes in, security comes in. So if we're sensing that there's some heightened anxiety with the trying to get us all coordinated, to come in and hear the questions that need to be heard together, the plan that needs to be heard together, as long as having 5 people in the room won't be the stress, or just trying to be more coordinated with what that experience is like. So that's minimizing the repetitive evaluations, letting the child take a break, switching up staffing when possible. I mean, staffing gets exhausted, the staff can get exhausted, and the child, like sometimes just having a different person. I had a kid that I took care of as a pediatric resident who we got along great, and then I gave him with Child Life the news of his diagnosis, which was leukemia, and the parents didn't want to be there for it. And then after that, he did not want to see me, like I was not part of like his soothing team anymore. So just not taking that personally and being aware of that, and having some flexibility so that he could feel more comfortable. Decreasing stimuli in the environment. So sometimes the lights can be a lot, the sounds, and we don't have so much control over that if a trauma comes in. This is the level of sound that we need, right, for the care that we're providing, or just machines beeping, or as you escalated parents kind of riling up other parents while they're waiting, and we've definitely had that with Bert's that were waiting for admission. Using the parent as a model, putting the blood pressure cuff, or like you're going to put the otoscope in the ear, that type of thing. Team-based is similar, the minimizing repetitive evaluations. Okay, I think we did all that. You want to do this?
Sure. So, these, we're going to kind of go over some techniques. Some of them are very much intertwined, so I'll try not to be repetitive. But I think the big piece is knowing when to ignore a negative and reinforce the positive. So we want to ignore the behavior that is attention seeking or just negative behavior that's not conducive to whatever we're trying to get done, and reinforce any little small acceptable behavior that we might see. And the only time you would ignore negative behavior is as long as it's not a serious risk of injury, so just keep that in mind. And part of the ignoring technique is you actually need to avoid eye contact completely. and then you make no response at all. So you might also hear it called extinction. One thing to keep in mind when you do ignore behaviors or put behaviors on extinction, you do see a period of what we call a burst of behaviors right thereafter, but you gotta kind of, I call it ride the wave, and then the behavior will dip back down. So as long, again, as there's no risk of injury, just ride that burst and continue on. And as soon as you see an acceptable behavior, as simple as, good job, you just drank the water, or wow, I like the way you're sitting right now, good job. It's just the idea of highlighting what they are doing correctly and not giving attention to what they're doing that's disruptive.
And they will learn that the attention only comes when they're doing something that's approved. What I do see around the ED a lot, and what I get is a child that's really using words towards me or towards staff that kind of pull towards a response from us, and ignoring that can be really, really challenging and difficult, especially if they're saying things that are activating, even about hurting themselves or hurting somebody else. And those are things that we will assess when appropriate, but if I respond to them at that time, then it's not really, it's going to show them that this is how they can get attention, and then they will do it again at the level where they got the attention. So if you let it escalate and you don't ride that wave, and you give in at the height of the wave, that's where it's going to start next time. They're not going to slowly get there, and I won't have a chance then to stop it before, so I know that I just triggered them to start here every time, and now it's going to be a lot harder to get them to decrease, because that wave is just going to get bigger the next time.
And I think the trick is engaging the parents, because the parent will reinforce it.
Yes.
And the parents have all kinds of ideas about how the child needs to behave with us that I don't actually care about. The parent's like, make eye contact. I'm like, just answer my questions. Look wherever you want. I don't really care about if you're looking at me or not. I just, if you can look at your phone and answer all my questions, look at your phone. So engaging the parents in the conversation. So if the child is starting to do things and the parent's trying to say, don't do that or do this, just to say, hey, Mom, look at me. Let's talk. Tell me about this. What do you think about? And you can talk about anything basic. Reassure Mom, this isn't bothering me. I see this all the time. Everybody's safe right now. Tell me about your job. Tell me about this. Whatever other questions you might need. And then and just kind of reassuring the parents, because their anxiety, they will reinforce the behavior, because it's so embarrassing to have your kid act out in front of the doctors or the nurses. Or
even when they're using bad words, I do say, I understand that those are not words that are acceptable or appropriate for what you're trying to teach him, but it's really helping me understand what's going on and how he's feeling. So for right now, I would just like to be able to hear him out and see what he's saying. I know that he's just really scared right now, and that he doesn't really mean those things towards me. I'm okay in the room. Just, right now, let me just listen to him for a few minutes, and then we can talk to him later when he's calm about what's appropriate or not.
Perfect. And so then we want to provide structure. We want to explain, sort of narrate what's happening, give visual schedules, reminders, involve the parents. And this, I'm going to kind of talk about provide structure and slow transitions. Part of providing that structure is sort of prompting the individual to know what's next, so that way we can kind of help them remain calm, model remaining calm during transitions. Oftentimes we're moving fast, and so we don't realize the energy that we're bringing into the space, and that can trigger both the parent and the child. So just kind of being mindful of that. And I think, the bottom are just sort of quotes. But I think you guys get like the gist of it.
Yeah. And we hear you guys say these quotes all the time, so we're very happy.
Great. So the big piece is redirection of attention. You'll hear us talk about distraction a lot. It is your friend, distraction, and I know you guys are probably well versed in this as well. I remember being younger and shots and having to, a nurse basically being like, count to 10. I'm like, 1, 2, and then she hit me. I'm like, that wasn't 10. I didn't even get to 10. But that's a distraction technique. That was great. So, so again, redirecting only if there's no risk of injury. Still ignoring that negative behavior. So they might be doing something that is unacceptable behavior. But we're gonna be completely ignore it, don't even call it out and say, hey, let's play Play-Doh, let's give high five, engage with the parent to distract the child. And so as soon as they then engage in that distraction technique, you wanna reinforce, good job playing with the Play-Doh, et cetera. So we wanna simplify things. When people are really, really escalated, they're not hearing more than 3 to 5 words. And so sometimes, again, our own anxiety drives us to give big, long explanations of things, and they're not hearing any of that. So you want to simmer it down and basically give the very clear, direct demand or request. Put your hands on your lap, step down, very good. And again, when you are giving those very simplified requests, you want to reinforce